on this morning to review this 5th standard. We're going to get started here, so if you have any questions as I'm going through, don't be afraid to stop and ask. So again, looking at Standard 5, all about tracking and coordinating care, looking at lab images, referral tracking, and how we coordinate these different actions with outside facilities, hospitals, specialists. So you can see there are 3 elements that make this up. The intent of the standard, again, the practice tracks, tests, and coordinates care across specialty care, facility-based care, and community organizations. Element B there being the must-pass out of this standard, which is the referral tracking and follow-up. A couple of things that align with meaningful use, and obviously we'll note them as we go through. And obviously wanted to mention I had a few questions. Anywhere that there is meaningful use alignment, where we can use those meaningful use reports, the same exclusions that go with those meaningful use requirements that you've been used to before also apply here. So if we're using a meaningful use report for a time period or reporting period that there was exclusions, then we could also use those here as well. Getting into the first element, element 5A, this is looking at your labs and imaging, so test tracking and follow-up. One thing to point out with this element is that there is 2 critical factors. I believe this is the only element that has that, so to reach the highest score, you need both of those factors to get those maximum points. And they're very similar, just looking at 2 different things. So looking at factor 1, is looking that you track lab tests until the results are available, and flagging and following up on any overdue results. Factor 2 being the same thing, same type of process for your imaging tests. And I will show you some examples of a report that Medent has created for us to do this. Looking for some feedback from some of the offices, and I've talked to a few before about your current process for how you do this. We do have this report created that could be a useful tool if the following up and flagging part isn't being done right now. So again, I'll show you that in the examples. Let's see here. Factor 3 is that you're flagging the abnormal lab results, bringing them to the attention of the clinician. Obviously, we could do that through Medent. Factor 4, flagging abnormal imaging results, and again, bringing them to the attention of the clinician. Factor 5 is that the practice notifies patients of normal and abnormal lab and imaging test results. So the key thing being there that you're including the normal results. And this is something that is done proactively. It's not putting the results into the patient's medical record to review them at the next appointment that they have scheduled. This is being proactive and informing the patients about those either normal or abnormal results. Factor 6 follows up with the inpatient facility about newborn hearing and newborn blood spot screening. You can see there NA for adult practices. I spoke with, I think, all of the pediatric sites about their process for this and how they currently follow up with that. Factor 7, 8, and 10, you can see here are the meaningful use requirements. So factor 7, more than 30% of the lab orders are electronically recorded in patient record. And factor 8, more than 30% of your radiology orders are electronically recorded in the patient record. Factor 9, electronically incorporates more than 55% of all clinical lab test results into structured fields in the medical record. And you can see there in the bottom on the right-hand box that I included for factors 9 and 10, looking up the information in separate systems and manual data entry into the EMR does not meet this factor. I think you're familiar with some of these things, incorporating these results and tests from the meaningful use. But looking at factor 10, more than 10% of scans and tests that result in an image are accessible electronically. So a scanned PDF of the image in the medical record that could be retrieved and reviewed by the practice does meet that requirement. Again, not something that you looking up in a separate system and manually enter would not meet that. The scoring for this element, 6 points available. You can see there how it factors in factors 1 and 2 to get to those highest points. The documentation requirements, for factors 1 through 6, they're looking for a documented process and some type of evidence showing how the process is met. So reports, logs, different examples, and noting there that it's not just looking at one single example if that's the way that we're looking at that. Again, through some of these meaningful use reports that MEDENT created for us should be able to satisfy those as we're going through. Factors 7 through 10 there, you can see the 3-month report that they're looking for. Factor 9, since that's not a meaningful use requirement, maybe not something specifically more aware of. So just to note there what they're looking for, the numerator for factor 9 is that number of lab tests whose results have a positive, negative, or a numerical result, which are incorporated as your structured data, with then the denominator being the number of lab tests ordered during that period with results as positive, negative, or as a number. So looking at which percent of those, what number of those are incorporated as structured data within the medical record. So here's just an example report, again, one that MEDENT had put together for us to look at. This one is specifically the report looking at the lab tests. So you could see there which ones are still open and obviously able to click down into those and see then that you could do your follow-up from there. And the same report is available for the imaging tests and laid out and looks the same way, showing you which ones are open. So again, in the ordered or scheduled status that have been open for 30 to 60 days. And imaging results report for factor 2 is available the same way, in the same format. Looking at element B, this is the must-pass, referral tracking and follow-up. Looking at factor 1, it's looking that the practice considers available performance information on the specialist when making referral recommendations. So basically, they want to see that there's something that your practice, that the providers look at when they are referring, that there's some type of quality or performance basis or background for that referral. As far as the documentation that we'll look at, obviously, on the next slide, they are just looking for examples for this. So this could be any type of health plan directories that have this kind of data, any publicly available quality and performance data. It could be from past clinical experiences and patient feedback. So if there had been consistent negative feedback or poor clinical results, just that type of process that specialist isn't utilized by the practice, or those types of things with good positive clinical outcomes are the basis for referring to them. Factor 2 maintains formal and informal agreements with a subset of specialists based on established criteria. So this is a little bit misleading because it does say formal and informal, which would put you under the impression that both are needed, but it's actually an or. So informal agreements is what most of the practices will be utilizing and be familiar with. This could be something as far as just your referral form with expectations embedded. So the time frame, any certain expectations within your referral form to give this to the specialist. And I have in parentheses there PCSP, so that is the specialist version of PCMH that our offices haven't started working with yet, but just wanted to point out that for the specialist portion of medical home, this element for us, which is 5B, is their first element. It's obviously something that is very much emphasized on the specialist program, that they also have these types of agreements and agree with getting this information back in the time frame that the PCP asks for, and also requires the PCP to send them the information that they need. So this is where everything is trying to close the gap, where these things kind of fall out of place and where we don't have results or documentation from one side or the other. This is where you can see that tying together, where this really does incorporate the specialist and this whole portion of care, and having this not fragmented in those areas. Factor 3 is maintaining an agreement with a behavioral health care provider. So this is just looking for you to have an example of at least one, and just kind of how you refer and what your aspects you're looking at with your behavioral health care providers that you refer your patients to. Factor 4 integrates behavioral health care providers within the practice site. So to receive credit for this, there is some type of incorporation in the practice. So in speaking with a lot of the offices, I know that this is not something currently happening and might not be happening in the near future. So it might be an area where we lose, that bit of portion, that bit of points for this element. Factor 5 gives the consultant or specialist the clinical question, the required timing, and the type of referral. So your reasoning for the referral, the urgency, and why that urgency is there, if that's the case. Factor 6 gives the consultant or specialist the pertinent demographic and clinical data, including test results and the current care plan. 7 and 8, 7, you see there is a meaningful use requirement, that the practice has a capacity for electronic exchange of key clinical information and provides electronic summary of care record to another provider for more than 50% of referrals. Factor 8 is your critical factor, so one that is very important considering that it's a critical factor within a must-pass element, that the practice is tracking referrals until the consultant or specialist report is available and flagging and following up on overdue reports. So similar to what we saw in the previous element with tracking labs and tests, this is tracking all referrals until that report is available. Again, we have a report that MedEnt had created for us that looks at all patients who have referrals for the past 6 months, and also includes a tracking column of the send packages and consult documents. So I'll show you, I believe I have an example. If not, it's one that I have ran a few times and kind of tried to tweak with MedEnt so that this could be an efficient way to track what is in there if the office doesn't already have a process that they're following right now as far as a way to monitor and follow up with these. Factor 9 documents co-management arrangements in the patient's medical record. So this one is looking that the primary care clinician and the specialist have some type of agreement that enables co-management of the patient's care. So if a patient regularly is treated by a specific specialist, outlining who is responsible for what's going to be entered into the medical record, and when and what type of time frame. So again, looking at who is responsible for what and having this arrangement with specialists that are seeing your patients most often. Factor 10 asks patients about self-referrals and requesting reports from clinicians. So what you do as far as asking patients if they've seen anyone else, if they've self-referred, if they've gone anywhere that the PCP is not aware of, and then going forward to request that report or information from the specialist if needed and documenting in the medical record. The scoring, 6 points possible, and then looking at factor 8 as being your critical factor needed to get to the maximum point. Noting again that this is a must-pass element, so obviously looking to get the 100%, but for this must-pass element, the requirement to move forward with recognition is that 50% threshold. You can see there's a documentation, again, for Factor 1 examples of the type of information that the practice team has available on specialists. In the process policy template that I have made available for this element, it does outline a little bit in there certain things that you could be looking for and give you some ideas of how you can outline that process. Everything else is pretty straightforward, looking for different examples, materials showing how behavioral health is integrated in the office. And then again, a documented process in either a report, a log, showing how these referrals are tracked and followed up with. Just a few examples here. Again, this is taken from the process template that I have provided. You can see there that I just took pieces from this, looking there specifically at factors 5 and 6. So here giving the consult or specialist the clinical question, the urgency, required timing, making sure that you give them demographic and clinical data. So just outlining how that process could be done. And then on the right-hand side, looking at factor 3, this is that maintaining an agreement with the behavioral health care provider. So you can see there in the first sentence on that right-hand side, it clearly states the practice does not provide mental health and substance abuse treatment. So that is perfectly fine to note within your process. That's where you're able to explain that you don't have that treatment in your practice, but then going further and outlining what you do for those patients. The third element, element 5C, coordinating care transitions. You can see here there is one factor that has the meaningful use requirement, but going through, factor 1 is that the practice proactively identifies patients with unplanned hospital admissions and emergency department visits. Clearly something that we're already doing, working with, want to see that you're working with local hospitals, with the emergency rooms, different health plans to identify patients who were hospitalized and had ER visits. Factor 2 shares clinical information with admitting hospitals and emergency departments. Factor 3 consistently obtains patient discharge summaries from the hospital and other facilities. And again, if you haven't looked at this, and we will look at it for the documentation for these factors, they're looking at your documented process, so how you go by getting that information or providing that information. And then for most of them, it's 3 examples that they want to see of the patient information sent to the hospital, or 3 examples of the discharge summary for factor 3. So just to keep in mind that that's those few examples of and how this process is done is what they're looking for. Let's see, factor 4 proactively contacts patients for appropriate follow-up care with an appropriate period following a hospital admission or emergency department visit. Factor 5 exchanges patient information with the hospital during the patient's hospitalization. For that one specifically, they do look for one example of that two-way communication. And factor 6 obtains proper consent of release of information and has a process for secure exchange of information and coordination of care with community partners. And factor 7 being your meaningful use requirement here, exchanges key clinical information with facilities and provides an electronic summary of care record to another care facility for more than 50% of patient transitions of care. So looking at the scoring for this element, again, 6 points, with all 7 factors being what you need to reach 100%. No critical factors within this element, so the scoring's pretty straightforward as to what factors required for what percent. And then your documentation, as I mentioned, a documented process for all but factor 7, which again is our meaningful use requirement. So that 3-month report and either a screenshot or some other document showing capability for that factor. But the rest you can see there, the documented process and 1 to 3 examples of how that process is followed through in the practice. Does anyone have any questions about any of those elements? It was kind of a quick one, kind of straightforward as far as what is needed and the processes. The biggest thing is how we're doing this and how we're going to be tracking it. So again, as I mentioned, I believe in the first element, I spoke with many practices about their processes currently. And that flagging and then following up piece is what seems to be missing right now. So whether it be that these reports are able to be run on a weekly or monthly basis, and then we have an easier way of tracking what's missing and then following up with them, whether it be by phone or however that communication occurs. So any questions that come up with this or doing it, please let me know. The last standard, Standard 6, looking to have that webinar in 2 weeks, so the 23rd and 24th of July. So then at that point we would have had a webinar for each of the 6 standards and discussed a little bit of information about each one. And I can say right now, from when we first started and did the Standard 1 webinar, we've gathered a decent amount more information, probably on each standard that could now be incorporated, more examples, more explanations. So going forward, I'm going to be talking with different practices, taking suggestions as far as which webinar topics after discussing Standard 6 would be most beneficial. So whether it be going through, again, a specific standard that is a little confusing or has a lot of information, looking at just the must-pass elements and critical factors so that we know for sure we have what is required of those, anything more general. So feel free to give any of that input as well. So if there's no questions, we can end now, and I will be in touch again with next webinar information, and I hope everyone has a good weekend.